Hi, I'm Michael Barr, President and founder of Metis. Thank you for listening to this pre-recorded session. I know we won't be able to interact during this meeting, but feel free to contact me afterwards. All of my contact information will be at the end of the presentation. And today's topic, how should practices prepare for value-based care? A very important topic. Some of you are probably struggling with this. Hopefully some of you are succeeding and can probably teach what I'm about to talk about, but let's get into it. I believe in bottom line upfront. So let me just say success in value-based payment models necessitates data-driven decision-making rooted in high-quality data produced by efficient operations tracked via clinical and operational dashboards that deliver actionable intelligence. A lot on this first slide. We're going to dig a little deeper into each of these. Again, given the time limitation, I won't be able to get too deep into this, but hopefully you'll walk away with some tools, ideas, and questions, which I'm happy to help you with. So what's in scope and out of scope for today? We'll talk about areas you can and should influence. We'll identify some frameworks, tools, and potentially some guides. What's out of scope is any in-depth review of value-based care models. I'm not going to get into health policy discussions or recommendations. I'm certainly not going to discuss any specific technology solutions, though I will give you a light framework for you to help you assess technology options as you start to think about what functions you need to address to be sure you're successful under value-based care. So let's just talk a little bit about value-based care, what the goals are. So high quality, lower cost, improve experience. Let's remember that that experience includes all of you and your clinical team members and your administrative team members, essentially everybody who helps you in your practice. The disconnect is that the real world outcomes from some of the models are not meeting the goals, despite a pretty significant interest in advancing value-based care. So I don't think value-based care is going to disappear, but I think, as you might have heard from the Centers for Medicare and Medicaid Innovation, they're looking at different ways to drive value-based care further. This represents a lot of challenges for physician executives and others because you're probably operating in mixed models and fee-for-service. So you have value-based care and fee-for-service, sort of the two-canoe problem. Data complexity and technology overload. So you're getting a lot of data. Not all of it is good. Not all of it is designed for the purpose that you're seeking to use it for. And you're probably getting pitched or already have multiple different technology solutions, none of which really answer all of the questions you need to have answered. And of course, all of this leads to burnout across all members of the team. And sometimes it'll appear that there's an unclear path to success. So again, just to hammer home some of the critical functions for success, the data-driven decision-making, real-time insights from actionable and accurate data, broad care coordination across the full network of your care ecosystem, if you will, paying attention to quality measures and reporting, specifically HEDIS, the Medicare Part C and D, and other state-specific programs, but recognize that those measures are usually retrospective looking back. We need to think about what you can do in the here and now to assess sort of those leading indicators of how you're going to perform down the road. And some of the measures that are used in accountability probably are not well designed to help you with your quality improvement initiatives. And then, of course, getting your whole team behind this, engagement, including the workforce, incentives, your payment models within your practices or your health system, making sure everybody's knowledgeable about the options and the opportunities, and of course, addressing burnout. So let's dive in. How should you navigate the value-based care maze? So one of the models that I like to use is from Leadership Strategies. It's called the drivers model. And this is a very high level pre-prepared slide. You need to think about this and use it as a tool within your system or your practice to think about where you are now, the current situation, and where you want to be, your vision. And that is the way you get there by looking at the drivers, both the barriers, the success factors, and the individual activities that you need to address in order to get to that vision. And I pre-populated this with my colleague with several different points, but these may not be pertinent to you, but just to give you by way of example, what are some of the critical success factors potentially? Sort of training your staff on pop health and clinical practice, seeking alignment across the different payers, because more than likely you're dealing with several different types of contracts, and then looking at your technology and data analytics infrastructure, trying to use the least amount of technology to get the biggest bang out of it. So you're not having different technology solutions from multiple different things, looking for something that can help you across multiple different ideas or needs and functions. And thinking about the barriers, because some of those success factors will cost you money, so significant implementation expense. You may have some limited time and resources, or you may feel like there's a lot of cultural change and digging in of heels that's going to prevent you from getting the change you want in your practice or your health system. And of course, as I mentioned earlier, you're dealing with multiple different value-based care initiatives and differences across your payers. So what do you need to do? These are the drivers. So you have the success factors, the barriers, and here's some of the drivers. Again, I'm not going to go into all of this now, but if you take a look at the slide, you'll probably recognize some things that you could be doing now, like assessing your current performance so you know where you want to be or where you need to be successful in value-based care, and so on and so forth. I will share these slides, and the link to the leadership strategies drivers model will be in the slides. Another way to think about this is categorizing the jobs to be done. So looking from the bottom up, the organization and infrastructure, the personnel and training, getting everybody ready and on the bus, really implementing team-based care so everybody's pulling in the same direction and operating at the highest level of the license, skills, and abilities. Streamlining workflow and logistics. Don't accept what is, because what is likely been sort of changed over time based upon small, challenges and not as well thought out of from soup to nuts, from A to Z. And then thinking about data and technology. These in this bracket are very slow to change. They have to be done. They are table stakes, but you might get some bigger, faster returns on focusing on data and technology as long as it's used as a tool to supplement what you're doing and to help you streamline some of the other activities. What do I mean by that? Let's take a look at it this way. There's lots to be done across all of these different levels of this pyramid. I'm just going to build out the slide. So you have a lot of activity in the organization infrastructure, bottom left, the leadership, the governance, contract management, and so on. Personnel training, we already talked a little bit about cultural awareness, making sure people are ready to change, the patient-centered care aspect, all the QI strategies, population health, and data analytics, training people on those. Then you have the team-based care, who's doing the care management coordination, how do you know that it's getting done, what is happening with optimization of prescriptions, which I'd encourage you to really look at. That would be optimization of medication adherence and management, because many of those measures you're assessed on are related to medication adherence, optimal medication management, and if you have access to clinical pharmacists, either on a part-time basis or contract basis, I would highly recommend you get them involved with your most complex patients. Then you have a lot of workflow and logistics issues. What's your model? How are you coding the hierarchical clinical conditions, HCC, or risk adjustment factor, RAF scores? Are using artificial intelligence, natural language processing, clinical decision support, and so on and so forth. And then you have the data and technology, and that's where I want to focus is the most pressing opportunity to improve what you're doing now is making sure the data you have and are using is suitable for the purpose that you need and that you're accessing the data you need from multiple different sources. To sum it all up, these are the first two priorities if you're going to do value-based care according to my framework. Focusing on your quality metrics, what do you need to do, what's the data you need to do that, and all the different sources of data, and then using that to optimize your clinical model, sort of both ends of the same spectrum. Let me put this in a slightly different way. This is kind of a logic model to optimize value-based care performance. You have the clinical documentation technology and administrative functions, and the idea is that you will focus on data quality improvement because that is going to drive your workflows, help you with reduced clinical data or missing data, and improve your coding for hierarchical condition HCC scores and risk adjustment factors. So if you're in a Medicare Advantage, you need to improve those, not to game the system, not to overcode, and not to undercode, but to appropriately code all the conditions that your patients and your population have. With that, you will then be able to drive improvements in your clinical workflows, your administrative workflows, and your documentation and technology. Doing that gets you to better quality reporting and patient and clinician team engagement to improved performance measures. So going across the bottom, documentation and technology efforts support clinical administration operations that positively affect workflow, data, and coding, lead to data quality improvement, which enables better patient engagement and reporting, cascading to better performance rates. I jumped in the middle, the big yellow arrow. I believe data quality is where you should start focusing now because, according to the pyramid, you can get some quick wins and improvements by focusing on that because the others are slower to achieve. Doesn't mean you ignore them, it just means you have sort of a prioritization. Thinking about clinical performance, because many of you are clinicians or physicians, and I think that's important. We all want to do well. So, what are the measures that are the most problematic in your practice that are limiting your ability to be successful in terms of value based care? But more importantly, what are they doing to you in terms of your pride and your professionalism? So, what are those measures that are bothering you? What are your clinical protocols? Have you improved them or addressed them lately to improve them? Why is the performance falling short? So, they're asking 5 whys. Why is this? Then the answer, why is that? Why is that? Keep going and driving down the 5 whys model. You may have whys WHY, not WISE, although using the 5 whys model is a wise thing to do. Are there common issues across measures? Are you having trouble with those measures that require you to do something when something happens to your patient? For example, emergency department encounter, post-discharge, transitions in care, medication adjustments, and so on. Are those common issues that you can address across multiple different measures and situations? Within your network, if you're multi-site practice or an ACO, is there variability? And why is there variability? Where are the better performers? Where are the not so good performers? Can you address that? Can you do some internal learning and cross-pollination of good ideas? Similarly, by geography or population, what's driving some of the problems in a particular population or issues? And then looking at patient experience and satisfaction. Sometimes that's a proxy for what's going on in the practice. Um, I'll never forget, I did a project where we visited 34 practices in 14 states several years ago. And I had a clinical team and I had an administrative team. And by the third or fourth practice evaluation, the administrative person, the clinical people could tell the administrative person what he would find in those his evaluation and vice versa, because things were reflected across the entire practice. So if you see something someplace, kind of ask, well, how is it affecting the clinical record? Or if the clinical record is a mess, how is it affecting our referral network and referral process, and so on and so forth? As you think about your measures, I like to group them in different sort of categories. So you have chronic conditions, preventative measures, other situations, and post-event follow-up. Each of these have different sort of common strategies. So for chronic conditions, you're really going to need a recall reminder system, so interactive voice response, email, text-based reminders, and so on. Using AI, call a chatbot or something like that. You're going to need to do some predictive modeling. Who's going to worsen? How do you address those populations or those people who have chronic conditions and get them into care on a regular basis? You're going to need context-sensitive clinical decision support. And as I mentioned earlier, I'm a big fan of clinical pharmacy outreach or pharmacist outreach for medication adherence and optimization on these chronic conditions. And then you have self-management apps. I'd encourage you to look for an app that goes across multiple different conditions, not a diabetes app, not an asthma app, but something that can be flexible and extensible across those conditions. If you like a preventative care, there are certain things you need to identify who needs what and when. This is particularly important in the pediatric preventive care in terms of vaccinations and so on because of the timelines, especially early in childhood. Do you have the systems in place that can identify those children who need those immunizations ahead of the time when they need it so you don't miss an opportunity? Because if you miss an opportunity to give some vaccine on that schedule, you pretty much have lost that measure, especially in the combo measures, combo 10 and so on. Post-event follow-up, medication reconciliation post-discharge, post-hospitalization for mental illness, or post-ED visit for mental illness, or planned all-cause readmissions. Those are post-event follow-ups, so there's a timeline. You need ADT feeds, you need automated discharge follow-up protocols, and so on and so forth. And then for other situations like prenatal care, pre and postpartum care, transitions of care, patient experience, think about maternal and child health programs. You're getting the mom and the baby or babies into care and kind of treating them holistically across the duo, the two of them. Home visit programs, behavioral health integration to address some of the prenatal or postnatal depression. And then, of course, getting community health workers out there to help a lot of the care that you need. So think about these categories of measures and what you can do for one that you can extend to the others, like recall reminder systems, standing orders. I did mention that in preventive care, community-based activities, and workplace activities, and so on. So hopefully this helps in terms of looking at the measures and thinking about strategies across several different measures. And then using insights and data to drive outcomes. So identify evidence-based strategies to address root cause analysis findings. So when you see a poor performance, what's driving that poor performance? How do you get to that root cause? Is it an internal? Is it an external? Is it a community-based issue or social needs or social risk issues of the individuals? Try to align your interventions with the population needs based on the analytics and stratification, such as health-related social needs, geography, and predictive modeling. And then don't be afraid to experiment, not with people's lives or the quality, but with the processes that you're trying to use to improve this. So you pilot, assess, revise, or remove, and then repeat and continue that continuous quality improvement effort. Getting to data now, is your current EHR based upon an application programming interface or API first architecture? If it is, you have multiple opportunities to plug and play different technology options. Not literally plug and play, because there's never anything that's exactly like a plug and play, but much easier than if you're trying to knit together custom sort of solutions that don't really talk to each other. Look at your vendor data access agreements. Do they support third-party apps connecting or accessing your data? So you can bring in best of breed or different programs that can help you with some of the ideas that we've been discussing. Does your practice management system facilitate patient outreach, enrollment, engagement, and care management capabilities? Think about sort of campaigns. You have diabetic population, people with diabetes. Are they getting all the hemoglobin A1Cs, foot exams, pneumococcal vaccinations? Can you initiate a campaign? What about those folks who haven't picked up their prescriptions? You're concerned about medication adherence. Do you have sort of the ability to initiate a campaign, identify those folks, maybe tag them to a clinical pharmacist to do some of the outreach? And do you have agreements with the major providers, hospital systems, ACOs, other big group specialists in your community, or of course your health information exchange for data to flow bidirectionally? You become part of the system when it's bidirectional. You both contribute to and get returns from that data sharing. Now, this is a really complicated dashboard done for a different purpose, but I wanted to present it here to show you how you can start thinking about data flow. So you'll see across the top, we have the external data sources flowing into a data and analytics reporting module or computer, and that's driving multiple different metrics, key performance indicators identified at the bottom of this slide, at different parts of the chain. Now, again, for the purposes here, it's just to illustrate that you should think about doing this in your own practice, in your own setting. Where can you expect to get the information, from what source, and why, and how is it going to flow, who's collecting it, who's analyzing it, and how is it being reflected back into practice to help you generate better outcomes? Another way of looking at this is thinking with the end in mind. So these are your priority use cases: pop health, quality reporting, prospective HEDIS if you're driven by HEDIS scores, value-based payment models, risk adjustment, and so on. Think about those use cases and think about the data you need to support those use cases, right? All those different sources being driven into a requester or aggregator. Is that you? Is it your EHR? Is it your health information exchange? And then you pull data and start to refine it, right? Because you need that data for its particular purposes. And then you might have an analytics engine, a HEDIS vendor, or digital quality measure engine that's producing the data you need for your use cases. But garbage in, garbage out. Everybody's pretty familiar with that phrase. So you need to be looking at the data, thinking about how you want to refine it, whether it's NLP, natural language processing, algorithms, AI, data aggregator validation. Then thinking about, is it internal or external in terms of your data processing to produce data to support your use cases, and continue to refine that strategy. Another way to potentially look at it is similar boxes, but during prioritized use cases, look at your current performance, identify, quantify your gaps in care and your highest impact metrics. Those may be the more heavily weighted ones in Medicare stars. Look at your contract requirements, generate the hypotheses. I mentioned earlier the 5 whys. Look at root cause analysis and test those hypotheses. Identify internal, external factors. Expectation is your data completeness and quality will be the most critical factor affecting performance. Your goal is to identify the best sources and desired formats for those use cases. And then based upon those use cases, where should you expect to get the most data? HIE or Health Information Exchange, direct data from your network, In what formats are you receiving those data? And the expectation is clinical data will be the most challenging to obtain and improve other than your own. And the goal would be to encourage standards-based file format sharing, preferably via fast healthcare interoperable resources. And then to optimize the data, prioritize standard-based data feeds that cover a significant percentage of the membership or of your practice or the population you're covering. Your expectation should be that FHIR endpoints will be the best sources of standardized data, but will still require additional uplifting or improving. And the goal is to get FHIR endpoints and others to give you data and encourage more of them to encourage adoption. So using more of them will get them more online, so to speak. The goal is to get FHIR endpoints up and running so that you can tap into these data and use them for your use cases. Now, I mentioned technology a few different times. Here's a very high-level framework to evaluate your options. Does it meet your priority use cases? Does it support risk stratification, predictive analytics, care management, quality reporting, and financial reconciliation? All the bedrock functions you need to succeed under value-based care. Then, does it integrate with your existing platforms? Does it ingest the data you need from those sources you've identified? Does it potentially use artificial intelligence or natural language processing to analyze and provide those insights? You don't have to pay a huge analytics person. You still need human oversight. It's a totally different topic. But can you use them? Are those tools available for you to help you? And then is the technology platform aligning with the current policy? Again, I'm not going to get into this, but we talked about fast healthcare interoperability, the Trusted Exchange Framework and Common Agreement, or TEFCA, the CMS, or Centers for Medicare Services, Medicare Medicaid Services data sharing mandates, and do they have the appropriate certifications for security and trust? And then what's the rollout plan? What's the implementation? Can you get people engaged to use this? What's the technical support like? What are your expectations? What are the performance expectations and service level agreements that are part of these agreements or part of these contracts? Look, I've covered a lot in several minutes here. Some of it, I'm sure, is raising more questions and giving you answers. But at the end of the day, whether you look in the driver's model, the clinical categories, the pyramid, or looking at data, value-based care and performance is a math problem. And you must have the right data to solve it. I'm hoping that this presentation helped you understand the importance of that data, not to exclude other very important functions and issues you need to address in your practices and health systems, but getting the data, getting it right, getting it usable, getting it higher quality, getting it from the sources that cover the most needs that you have, focus for the particular use cases you've prioritized is the best way to start seeing improvements in your value-based care performance or get you ready for future contracts. Well, I hope you found this helpful. Here's my contact information. I'm happy to hear from you. Thank you very much, and good luck with your value-based care performance. Bye.